All right. That looks pretty good. Well, it's the top of the hour, everyone. So, welcome to RD Exam Ready Live. My name is Zach Caseberg. I'm your tutor, your coach, your guide along the path to passing the CDR exam. And one of my biggest passions is to help RDs and help RDs to be just like you, to know how to effectively pass the CDR exam and help give you lessons along the way. And so, if you're joining us and you want to learn more about that, then hey, you're in the right place. Tonight, we're going to use our time nice and effectively because we're going to go through a topic that kind of hangs up a lot of students here, everyone. One of those topics being medications. I love talking medications. It was always a weak point along my path, along kind of my dietetic internship, even when I was working as a clinical intern and a clinical dietitian. I was always kind of never felt like I was in a strong point with medications until I was doing things in practice, right? Maybe a lot of you agree or disagree with that statement. Let me know in the chat if everything sounds good as far as that goes. But we're going to talk through medications a little bit tonight. I'm going to be pulling up some kind of sheets for us to take a look at and go through. And then just a reminder here, students, if you ever want to get PDF notes of these sessions, all you have to do is join the mailing list. I'm going to drop that in the chat at some point, probably, or just put it in the description of this video. And if you join that mailing list, I'll get that emailed out to you, or you'll have my email just so you can reach out. If you say, hey, I would like to get that PDF, you can let me know, and I can get that distributed or just kind of show you where to find that. Okay. All right, everyone. So if everything looks good, sounds good, let's dive into our session on medications. Before we dive in, one thing I want to keep in mind, couple just kind of basic rules. My big recommendation is you're going to get the most out of this session if you stay engaged. So if you use that chat function that's on there, you're going to be able to send me messages, let me know where I'm not being clear on something. Maybe you have a clarifying statement, or maybe you learned something in an internship and an experience, and you want to maybe ask more about that or clarify that statement. That chat is going to be exactly what you do out of that. And so I really recommend you try to engage. Don't feel like any question is a stupid question. I am of the belief there is no stupid questions when it comes to a topic like this. So definitely use that chat function. And then secondly, yeah, just keep it positive. We're going to do some practice questions today. And remember, this is all about practice. This session is not meant to shame you, to make you feel like you're not in a good spot, to make you feel like you're not good enough. It's not at all what the point of it is. It's just to test your knowledge, see where you're at, and give you some resources as you study beyond. Okay, everyone. All right, so it seems like we're sounding good. Let's go ahead and let's dive into our session here. I'm going to share my screen. And we're going to get into it. So we're going to have about 3, 4 pages of medications that we're going to go through. There will be some medications on here that maybe you've never seen before. There's going to be some that you are like, hey, Zach, I think you're missing this medication. This is not meant to be a total comprehensive list of every medication you've heard of or even every one you've seen on a question. That's not really what our point of it is going to be. Rather, what we should be thinking of this session is thinking of this as like, okay, so we're going to focus on the big major medications that we need to know for exam day. Um, and so when we're kind of doing that, just make sure you're kind of looking at what the information I'm giving you here. So on the top on this margin here, I have the drug type. Now this is going to be kind of like the category of the drug that we're going to talk about, such as acid inhibitors, a big general term for drugs or medications that inhibit acid. Then we're going to go through the class. So, during the class, we're going to talk about kind of the different subtypes of this medication. I'm going to put there in the parentheses the ones that I think that are pertinent. I'm going to put in the parentheses what I think are going to be the generic names on the exam. Students have told me before that they see the generic names, they see the class names, they see a little bit of both. So when it comes to that, that's kind of what you're going to see come exam day. You're going to talk through the purpose of it. So, kind of, it's good to know what the purpose is. Come back here. It's good to know what the purpose is going to be of that medication as well. And then it's going to be important, especially for exam day, to know the nutrition related interactions. That's what I'm going to really want you to key in on is nutrition related interactions that you see with this. Okay. Excellent, everyone. So if all looks good, let's dive in, and I'm going to keep an eye on that chat to make sure that you're all going to be telling me lots of stuff. Let's start out with the acid inhibitors. As I put here, acid inhibitor. Important term you need to remember: inhibit means to decrease, to reduce, right? For acid inhibitors, there's about three subclasses. There could be more, but these are the major ones I would say. We have H2 antagonists. I spelled that right, good. H2 antagonists will decrease acid production in the stomach. We have proton pump inhibitors, which will also decrease acid in the stomach. In third class, I would want to know here is an antacid. Antacids are really common because they are Tums, right? So let me know in the chat. You've heard of Tums, you've heard of antacids. Is this something you're familiar with? Now, purpose. What is the purpose of an acid inhibitor? It's to treat things or ailments that are due to excessive amounts of acid, or too much acid could be disrupting that ailment. Here's an example: gastric ulcers. When I have a gastric ulcer, maybe I'm someone who drinks way too much caffeine in coffee, irritants, and I developed a gastric ulcer for whatever reason, right? Well, excessive acid in my stomach, once that hits that gastric ulcer, it's going to hurt like heck. It's really not going to feel good. GERD, gastroesophageal reflux disease, usually is due to excessive amounts of acid that travels up the esophagus, right? So, acid inhibitors are really great for reducing that level of acid so it doesn't creep up as much. Make sense? Nutrition related interactions, these are really interesting. Now, when I do this, I'm going to just be nice and clear with you all. There's some of these things that on the nutrition related interactions, if I say that decreases, oh, come back. Why did it do that? Sorry about that. It decreases B12 in iron absorption. So if it decreases B12 in iron absorption, let me ask you in the chat, folks, what do you think we would recommend to the patient? If we have a decrease in B12 and iron absorption, as the RD, what do you think you're going to tell them to do? What are your thoughts? What are we going to do? What are we going to do if we see decreased B12 and iron absorption? Absolutely. We're going to supplement. We're going to supplement. Okay. So, anytime that I'm telling you that there's a decrease in the absorption of these things, most of the time, what I'm hinting towards is to say, hey, we would need to supplement it, whether that's a B12 injection, whether it's a B12 oral supplement, whether it's an iron supplement, or maybe it's even just foods that have more of those vitamins in them. Every time I'm telling you about a decrease in absorption, excessive excretion, we're going to have to probably supplement or make sure that they eat more of that food. I'll point these out as we go along the way. The reason we see a decrease in B12 and iron absorption with acid inhibitors is because of the stomach. Firstly, B12 requires acid to be cleaved off of foods. Remember, you have all that hydrochloric acid in your stomach. It's there to break foods apart, to break things to make them more absorbable. An acid inhibitor is going to make that a little bit more difficult to cleave that B12 off of those protein foods. Makes sense? Iron loves acid. It loves acid a whole lot. And I even saw someone in the chat do vitamin C. We know iron loves acid. So when you take something that inhibits acid, this is what happens. You just get decreased iron absorption. Okay, I don't know why that keeps going in and out. Okay, now this will be the point we take a pause a little bit. I'm going to shift down and I'm going to pull up our next medication here. But while I do that, if you have questions about acid inhibitors specifically, I want you to mention them to me. I want you to say something about them so that I can surely get those taken care of, okay? Good. And if I don't see anything, I'll just assume you're doing good there. Okay. All right, so I'm going to kind of introduce the hormones. If I need to come back to questions, I will. For hormones, we're going to have corticosteroids, prednisone. Prednisone will be the generic name that we see for a corticosteroid. Now, people take steroids mostly for the reason of fighting infections and anti inflammatory properties. You have a big infection like People like if you have pneumonia, you have a big lung infection, for instance. A lot of the times they'll give you a hormone to try to boost up that immune system a bit. Hormones have a lot of nutrition related interactions, folks. So check these out with me and make sure you understand them. If you don't, let me know in that chat. Firstly, one thing that hormones do is they decrease the excretion of sodium. By decreasing excretion, I put here in parentheses, it means we retain the sodium. So your mind should already be going, and you can let me know in the chat if we're retaining sodium, we're also retaining what? You can let me know in the chat there. Also, the negative that hormones are going to do is they're going to increase excretion of calcium, potassium, zinc, and vitamin C. So it's going to make our kidneys get rid of calcium, potassium, zinc, and vitamin C. Uh-oh, that's no good, right? We don't want us to be losing a ton of these minerals and electrolytes, right? Really, other common thing that we see is an increase in blood sugars when it comes to hormones like prednisone. In long-term use, due to that excretion of calcium, you can eventually see bone loss, osteoporosis. Those are really common things that will occur is osteoporosis as a result of taking prednisone long term. And then also, we're going to see an increase in appetite as a nutrition related interaction with this hormone here. Other note to make, this applies with so many medications, but in particular, it's mentioned to avoid grapefruit juice when it comes to prednisone or corticosteroids in there. I think these are so cool. I think to see that there's this many nutrition related effects, you're like, oh, this is really overwhelming. But look at all the ways that you can help a patient taking prednisone to help improve their diet, right? If you have questions about hormones or prednisone, or if you feel like I missed something, you can drop that into the chat. But this is my nice comprehensive list, I would say, of what prednisone really does here. Great. Moving right along. Good. We're moving on to pro-motility agents. Break that word down for me, folks. Promote. Motility, movement. Where is it promoting movement? It's promoting movement inside your gastrointestinal tract, especially the stomach. Metoclopramide is going to be the common, or sorry, not the common name, the medication name. Then the common name or the generic name is Reglan. This is one I used a lot when I was working in oncology, especially with patients with tube feedings. They would take Reglan because their stomachs would get so full of these big tube feeds. And they just couldn't tolerate it very well for one reason or another. So we would take Reglan to help move their stomach so they wouldn't feel sick. And that's exactly what it does. It speeds the emptying of food from the stomach. So it speeds that process up. Promotility promotes movement. When it comes to nutrition related side effects, here's what I mentioned here. You're going to have more rapid movement into the small intestine. A lot of the times you might think rapid movement and think diarrhea. I'm sure that's always a possible, but it's not something that's specifically mentioned for these pro-motility agents. Rather, what seems to be mentioned the most is it kind of talks about how if you are on an insulin regimen and let's say you take a short acting insulin or a regular insulin, you may be used to timing up your meals and your insulin regimen very closely. If I take a pro-motility agent, though, what's going to happen is that food is going to go quicker into that small intestine than I'm used to. So we might see a bit of a spike, a bit of an increase in blood sugars if you have diabetes and are taking insulin because the insulin that you're used to taking, maybe it just hasn't caught up. Maybe it hasn't caught up to how quick that meal normally hits your bloodstream. That's one of the bigger effects that I kind of see there. Great. Okay, I'm going to keep moving on here, but I'm looking out for those questions, folks. Oral contraceptives. Contraceptive, so birth control, that's what you think of here. Really interesting one about the birth control here. Obviously, it's meant to prevent pregnancy and ovulation. Some really cool nutrition related effects, though, that I see is a decreased absorption of vitamin C. I don't have the physiologies to why, it was just mentioned in the text, and decreased levels of folate in the body. Why do you think that, in my mind, what association do I make between birth control and folate levels? What do you think of? Why am I thinking of birth and folate? Why do I associate those two things in my mind? No, come back. There we go. Absolutely. Folate is helpful for baby, it's helpful for mom. And so I always associate in my mind that I go folate levels, birth control. I put those two together because I'm like, well, I already think of folate and I already think of babies. So I might as well think of it the opposite too, preventing babies in folate also. So I put those two together in my mind so that I just have that common association whenever we're talking about birth or pregnancy. So that's a tip I would kind of give to you too, is to remember that folate we think of with pregnancy, and then we can also associate it with birth control in that case. So just put those two together. Good, good. All right, now going on to our antidiarrheals. Easy word to break down: anti, against, diarrheal, preventing diarrhea, right? Lomotil is the name. Generic name is Imodium. Imodium here. What does it do? It slows your digestive tract. Specifically, it slows the diarrhea, slows things from entering your small intestine as quickly. And one really common side effect that it has, and this makes the most sense, is well, if you're on Lomotil or on Imodium, commonly, if you have diarrhea, you take this and then it swings you the other way. You end up with constipation because you took something that slowed down your GI tract so much that now you're constipated. No good. Okay. Not too bad of one right there. Gonna look out for questions though if I see anything. Appetite stimulants. Pretty self explanatory as to what they do. They improve appetite. Here's two that I wanted you to know: magistral acetate, also known as Megace, and dronabinol, also known as Marinol. Marinol. For those of you that might or might not know, one of these two is marijuana based, actually. So you can kind of guess between the two if you needed to. But our marijuana based one is going to be dronabinol. Dronabinol will be the one that is marijuana based here. I don't think it's necessarily needed to know, but I find it to be an interesting topic. And what you're going to see as a nutrition related side effect for something that's like that is you're going to see an increase in appetite. Okay, so you're going to see an increase in appetite. And thus, if we're eating more, you're going to see an increase in body weight as well, there too. So, not don't make it complex whatsoever. An appetite stimulant is going to increase your appetite, and thus it's going to increase body weight. That's what I would associate when it comes to those. That's assuming when they work. Sometimes we give them to a patient and they just don't work, right? We've seen that before. All right. Good. Taking just like a 30-second pause for questions here, and then we're going to move on to the next page. And since it's a little quiet in the chat, we're just going to keep it moving so I have plenty of time to go through those practice questions with you. Because I got 5 good ones that I really want to run you through. Okay, we're doing great here. Let's move on to stool softeners. Stool softeners do the opposite of that of an antidiarrheal. They treat constipation. Colace, milk of magnesia, Senokot, or Senna as it's also known, these all treat constipation. So if someone's constipated, they take this, helps you go to the bathroom. Nutrition related side effects. Of course, just like we saw with the Imodium, the stool softener, if you take it, it's going to cause diarrhea. So you just go too much at that point because it's moving everything much faster. Because of that diarrhea, remember, think about what kind of follows with the diarrhea. You're going to lose fluid, right? You're going to lose electrolytes. You're going to lose calcium and potassium. So, because of that diarrhea and the stool softener, you're going to see an increased loss of calcium and potassium from the diarrhea. And I add on to there, dehydration is going to be common because if you're losing so much fluid through stool, then what you're going to see is then loss of too much water and those electrolytes, like I mentioned there. Good. You all must be very strong in these. This is good. This is good here. Nice. All right, moving on to next is going to be antiemetics. Antiemetics. Okay, well, that's a little bit high there, isn't it? Perfect. Okay. Antiemetics against emesis. Emesis, folks. Remember, emesis is vomiting, okay, against vomiting. So it's preventing vomiting from occurring and treating nausea, right? Zofran, uh, prochloroperazine, or compazine as it's also known, are very good quality antiemetics and they treat nausea. And I should have put here treat vomiting as well. Okay, I'm just going to add that here. Nutrition related side effects, there's not going to be really any negatives, I would think. Decrease in appetite, wait, I'm so sorry, not decrease. An increase in appetite is going to occur, especially if nausea is causing appetite issues like that in cancers. Then what you're going to see is if you take an antiemetic, it's going to help bring that nausea down, and thus you're going to be able to eat a little bit more. Hopefully, an increase in weight would occur with that. But just to be clear, it's not the Zofran that's causing your weight to increase, it's the amount you're eating that would do that. So you're not just gaining weight because of the drug like prednisone would do. You're actually gaining weight because you're eating more. Okay, looking good. 14 great RDs to be in the chat here. Now we're going to move on to NSAIDs. NSAIDs here, non-steroidal anti-inflammatory drugs. That's going to be our NSAIDs right here. NSAIDs that we want to know for exam day are going to be ibuprofen, Advil, aspirin. These are going to be really common ones. Now, we're going to see some kind of consistent things between these here. Okay, so the consistent things that you're going to see between each of these different classes here is that they treat pain and inflammation. So they are anti inflammatory. Like I said, they're going to treat pain, decrease inflammation. And then they all do tend, I think it's little known because a lot of people just take ibuprofen every day, but it can cause stomach issues specifically in your stomach. Gastric ulcers are very common if you take these long term. GI irritation, bleeding can occur. Colitis is very common as well with long term use of things like ibuprofen. So then you might end up with like bloody diarrhea or issues with that too. So keeping that in mind here. And then for aspirin, just in the text, it mentioned that it may decrease serum iron, folate, sodium, and potassium with long term use. So just something to watch out for a little bit when it comes to the aspirin and those NSAIDs there. Okay. Now we're going to move on to diuretics. If you are holding on to your questions, now is the time to give them to me. Okay. I want you to understand diuretics. My goal for today is that you walk away feeling better about diuretics than you did prior to the session. Okay. So stay open to that. 3 different classes I need you to be familiar with, and they all serve different functions. Kind of cool. We have loop diuretics, also known as Lasix, Aldactone, which is known as a potassium sparing diuretic, and thiazide, which is a calcium sparing diuretic. That's what I'm going to call it here. Check out the function here. You can see the consistencies on here that it says it's going to treat edema, right? It's going to treat excessive amounts of fluid. That's what a diuretic does. If we're holding on to too much fluid, too much sodium, too much of anything, it really just helps us to start moving that out of our body and excreting it. That's the big thing that I would take from a diuretic is it's just helping me get rid of these here. We'll give some ideas here in a minute. So, one, with the loop diuretics, we're going to get increased excretion of potassium, water, magnesium, calcium, and chloride. You might be wondering why I didn't mention sodium there. Sodium is pretty much implied with all three of these, I would say. So I didn't want to give you just sodium. I wanted to actually give you what I think are the concerning ones to look at. I mean, sodium could be concerning, but I think when it comes to diuretics, we're much more concerned about some of these other minerals and electrolytes than we are with just sodium. So that's why I left it out here. With a loop diuretic, you know that it's going to have increased excretion of specifically potassium. And I'm going to say that again. Lasix treats edema, but it causes really severe losses of potassium. Oh, and Abe, yeah. So Abe the Bomb just mentioned in the chat. Also thiamine. Yeah, it wasn't mentioned in the text at all that I was reading, which was the Krauss manual. But thiamine being a water soluble vitamin, why don't we throw that in with the Lasix here too, as one that we could lose as well. So Lasix is a great like first line of defense one if someone just has general edema. But what we really have to be concerned about is the potassium. And I need you to remember that for exam day because it's very specific. Aldactone, that's our second one here. It's the potassium sparing one. This is the one you're going to give to a patient who is admitted with low potassium. If they have low potassium, low serum potassium in their blood, we don't want to give them a loop diuretic. We don't want to give them Lasix because it's just going to cause that potassium to go lower, and that's a problem. So we give them aldactone, the potassium sparing, which is going to cause excretion of water, magnesium, calcium, and chloride. However, it's not going to cause us to lose too much potassium, and that's the cool part about it. We can maintain that potassium level, not cause them to have major issues by giving them aldactone there. Third one here is thiazide, calcium sparing diuretic here. It's going to treat edema. Oh my gosh, why do I keep doing that? Edema, prevent calcium loss, and that should fit well into the nutrition effects here. It'll cause increased excretion of potassium, water, magnesium, and chloride, but it's not going to cause us to lose too much calcium in that case. Yeah. Good. So while we're letting those questions kind of settle in, let's think of some ways that we can kind of think of to help us to remember these. When it comes to remembering these a little bit, I mean, there's so many, there can be so many ridiculous ways that you try to come up with. Sometimes people you will use an AI model to help them come up with ideas. We can generate our own here. Whenever I think loop or Lasix, I always think of the loop of Henle. The loop of Henle is located in your kidneys. And the loop of Henle is where you get rid of all of your electrolytes and all of those extra minerals. So whenever I think loop of Henle because that's a really specific, like, weird name for a function or a part of the body. For aldactone, I can think of redact K. So aldactone, redact K could be one way that we could go about thinking of aldactone, a potassium sparing. There should be some good nursing videos out there too, or nursing like quotes and texts. They give you ideas for remembering aldactone as one of those. Bring that back. Thiazide, keep, calcium, high. So thiazide, keep calcium high. Those could be some kind of basic ways we can go about remembering those a little bit. All right, diuretics, taking a pause here. Any other diuretics questions at this moment before we jump on to our next med here? Good. Okay. All right. One we're going to move on to here, just taking a step off diuretics, is going to be pain management. Opioids, fentanyl, heroin, morphine. These are the types of things we're thinking of here. Narcotics, basically. They treat pain. That's what they do. People take them recreationally as well. Now, in the chat, everyone, depending on where you live in the country, you might see like opioid epidemics, you might see people on fentanyl. It might be something you actually really commonly see. If I were to ask you, though, for someone that's on opioids, would you say that they're hyper, active, talking fast, or low energy, talking slow, bent over, barely standing? What would you say? What do you think? I would say for someone who is on opioids, fentanyl, heroin, morphine, they're going to be very low activity. And that's what you're going to see with them. Very low levels of activity is what you're going to see with these types of patients. So, with that low level of activity, what that actually causes too is it causes constipation. Constipation is what occurs as a result of this. Okay. So, because they have constipation or because they have such low activity, one, they're not moving. So their bowels don't feel like that they're getting much exercise or movement in their diet or their body, right? The other piece is the opioids actually cause your GI tract to slow down as well. So if you're on an opioid, it's going to make everything slow down, including your GI tract. That's a really common thing you're going to see with opioids, pain management like that. No. Okay. And then I'm going to skip forward just a little bit, but we're going to come back to those ones I have above. Amphetamines. We're talking the other side here, folks. We're talking amphetamines, the other side of the drug scale. Methamphetamine, Adderall, coffee, stimulants, things that pep us up a lot. I put this person with the wide eyes here because they are like awake. With amphetamines, think methamphetamine, like someone smoking meth, for instance. Think cocaine, think Adderall, think things like that. These are stimulants. And what you should do with them is one, avoid caffeine because you're already stimulated, right? So you shouldn't really need something that's going to further stimulate you. Weight or BMI is typically going to decrease with use of amphetamines, okay? It's going to decrease. And I didn't have it on here, but I should have. It's going to cause low appetite. A lot of people have low appetite when taking amphetamines, taking Adderall, or taking things like that. Okay, so keeping that in mind when it comes to those. We talked about like the opioid side of it. Now we're talking about like the stimulant side of it. So just want to make sure you understand that. Oh, and then of course, when you're taking like a stimulant, you're going to have increased excretion, right? So you're probably going to be urinating more often. You're going to become dehydrated, I would imagine. That would be really common because you're moving so much, you're burning lots of calories, you're stimulated, you're having diuresis, things are moving out of your body quicker. Okay. Next will be anti anxiety medications. Anti anxiety medications, this would include things like Xanax, Valium, Ativan. The purpose of them is to suppress the activity, especially in the brain. So the nutrition effects that occurs is typically suppressed activity is one. And then it is recommended to avoid grapefruit. Grapefruit can really throw off some of these anti anxiety medications here. So just avoiding that, like we do with most things too. Okay. we're going to spend a few minutes on these antidepressants. And we're going to spend a few minutes because there's actually a lot of like nutrition related effects that have to do with these antidepressants here. So we're going to hang out on that a little bit for a minute and just make sure we kind of understand those. I'm going to move myself over here. Okay, sounds good. So when it comes to antidepressants here, we're gonna have a couple different classes. You have, I mean, there's lots of different antidepressants out there, but these are the ones that I think are most necessary for the exam day. We're gonna have MAOIs and then lithium. So we're gonna talk about these two separately here because they have very separate types of effects. MAOIs will decrease serotonin production, and then here's what happens with MAOIs. MAOIs cause an increase in blood pressure. They cause an increase in blood pressure, especially when they're combined with foods that are high in tyramine. Tyramine is going to be an amino acid that increases blood pressure. Okay. So here's those tyramine foods. Take a minute to kind of review those and see what you remember too. So, keeping in mind those tyramine foods would be like aged fermented meats, cheeses, pickled items. Those are going to be those major ones that you're going to think of there. Come back. Sorry, everyone. Screen just taking an extra minute or so. Okay, pause, everyone. Sorry about that. Oh, come on. Okay. Sorry, everyone. Tech issues. Give me just a second. Sorry about that. Very frustrating, I understand. There we go. Should be working now. Okay. Really sorry about that. Okay. We'll just keep it rolling there. Now, let's talk lithium a bit here too. Okay. So, lithium will be our next one that we're going to spend a lithium time on here. Lithium's a really interesting one, especially when it comes to nutrition related side effects here, because lithium is going to be that one that has to do a lot with sodium. Okay. Sodium is a big thing that's going on with lithium here. Okay. Now, when it comes to lithium on here, lithium carbonate is usually used to treat schizophrenia, bipolar disorder. Those are going to be the really common things that it's used for in that case. With lithium, this can be a little bit confusing, so make sure you just follow me here. Lithium can have effects with sodium. A high sodium diet will make you pee out more lithium along with the sodium. Okay. I've always kind of thought of them as kind of binding together or at least following each other a bit. So if I eat a lot of salt, let's say, yes, you're right, I'm going to retain some sodium. But if I'm healthy, my kidneys are just going to pee out the sodium, right? What happens is if I eat something way too salty, the lithium's going to bind onto it. And then when I go to urinate, it's just going to pass out of the body too. Okay. I'm not sure if that makes the most sense, but let's think of it to the other side. If I have a low sodium diet, if I decide, hey, like I don't want to do any sodium in that case, then what's going to happen in that case is we are going to retain more of the lithium, okay, in our blood. You're going to retain more of the lithium in that case because what your body is thinking is your body's like, hey, we don't have enough sodium, right? And so the lithium, it's kind of like free floating. It doesn't have anything to really hang on to in that case. And so then you have this higher circulation of lithium in the blood because under normal circumstances, it would just jump on the sodium you eat and pee out. But if it doesn't have the sodium because you decided to go on a diet that day, well, then the lithium is just chilling out in your blood. which is not good either because we want balance with use of lithium here. So sorry if that feels extra confusing. I'm trying to give my best analogies when it comes to it. Let's just repeat it again. If I eat too much salt, I'm going to excrete extra lithium, and then I won't have it to treat my bipolar disorder. If I don't eat enough salt, it's going to make me retain too much of the lithium in my blood because it can't go anywhere or pass out of the body. Question in the chat here. So, for bipolar disorder treatment, is it better to have low sodium to keep the meds in the system? It is better to have consistent sodium. That's what I'll say. So, if your normal diet is low sodium, let's say you normally just don't eat a lot of salt in your diet, then continue doing that because the lithium is going to be dosed according to kind of your normal levels. Okay. Not like your normal levels of salt, but they're going to measure how much it stays in your system. And so if your normal diet is just a low salt, like 1500 milligrams a day, then you would just want to maintain that extra, or you want to maintain that 1500. It's when you drop way below or you drop way above, that's when things get actually concerning there. Good question. Priscilla asks, so they'll need a moderate amount. Exactly, Priscilla. Yeah, we just want controlled sodium intake. That's a great way to put it. Moderate amount is what we're shooting for, about an average. Okay. Good. I'm just moving along a little bit here, folks. Great conversations. I love that you're asking about such an interesting drug here. It's really cool. Okay, antibiotics like amoxicillin, penicillin, a Z-Pak, they're used to fight bacterial infections of all kinds. Big thing though, biotic, kills bacteria. Well, I have bacteria in my body that's actually beneficial. Where is it located? Hmm. Well, in my intestines, of course, right? We talk about our microflora, and we're all big on microflora these days and keeping our gut healthy, our gut microbial system nice and healthy, right? As a way to put that. But what happens if you take an antibiotic? It kills off that microbiota. So this causes lots of diarrhea for people, overall GI distress, gas, and tons of issues um, because of that, because you're taking something that's killing off those good bacteria. It may interfere with folate metabolism as well. Not something that's as important, but I would say the GI distress is what you're likely going to see in a question. Doing great, everyone. I'm going to move on to our ACE inhibitors. I'll pause for questions at any point, though. For ACE inhibitors, we've got lisinopril, Zestril, benazepril, Lotansin. The goal of these is just to decrease blood pressure. That's what they do. So they decrease your blood pressure in that case, and they can cause increased retention of potassium. Okay, in the kidneys, we end up retaining a bit more potassium when it comes to taking ACE inhibitors in that case. Up above, I have one more comment on ACE inhibitors. With ACE inhibitors, like I said, they cause us to retain more potassium. So, what you need to do is avoid these things. So, avoid salt substitutes, okay? Salt substitutes, they don't have the sodium in them, but you know what they do have? A lot of potassium, ton of potassium. So, if my kidneys are already retaining more potassium, I don't want that salt substitute because it's just going to add more potassium. The same would go for a high potassium diet. I don't want to pack on fruits and vegetables like crazy because if I'm already taking and retaining too much potassium, if I eat a high potassium diet, I'm just going to increase and retain more potassium. It's no good there. Okay, good. A couple more pages, then we're on to questions. These last ones, just going to run through these a bit. We're going to talk anticonvulsants. Anticonvulsants prevent seizures. Keppra, Neurontin, Dilantin. These are things that can prevent seizures. One unfortunate side effect is it causes increased metabolism, aka increased usage of vitamin D, potassium, folic acid, and calcium. So basically, you would need to try to supplement or take a multivitamin with those things present because your body has a much higher demand for them when you're on an anticonvulsant. So, once again, folic acid popping up there, which I think is a good one in a common trend. All right. Statins. Statins, torvastatin, Lipitor, lovastatin, Mevacor. These are the kind of our common things there. What does a statin do? Well, it mostly treats heart disease or high cholesterol, right? So with a statin, what it's going to do is the goal is it's going to decrease my cholesterol. It's going to decrease my LDL, my bad cholesterol. It's going to decrease my triglycerides, which tend to not be good for my heart. It's going to increase my HDL, my high density, which is my good cholesterol, which all of these add up to what? Just preventing atherosclerosis. That's all it's doing there. Okay. Nutrition related side effects. There causes a decrease in coenzyme Q10, which is commonly associated with cholesterol and fats in this case. So we see a decrease in the serum levels of those. Um, we still recommend this, which is that people limit fat and cholesterol in the diet. So it's all to say, just because you take a statin doesn't mean you can just be eating like the fattiest of steaks, or eating saturated fat and butter all the time. That's not what the goal of a statin is. It's the goal is to bring those down to healthy levels. Avoid alcohol on a statin and avoid grapefruit as well. Those will be things you're going to want to avoid with a statin. Really common knowledge there. Wasn't always for me, but excellent. Anticoagulants, probably the most common one that you've talked about before, whether you're a dietetic intern or just one you've read about. Anticoagulants, warfarin or Coumadin, as it's also known, prevents blood from coagulating to avoid strokes or heart attacks. And I say coagulating, but let's just say excessively coagulating. I cut my arm, it bleeds, it coagulates, it stops bleeding. That's a good coagulation I want. But if I have too much coagulation, it's going to end up becoming a blockage somewhere in an artery or a vein. I'm going to have a heart attack, I'm going to have a stroke, something like that, right? With anticoagulants, remember, we want to avoid things that are high in vitamin K. So vitamin K has a pro-coagulation ability. So vitamin K helps me to coagulate. It's great for that. But whenever we're taking an anticoagulant, they're working opposite. So I want to avoid leafy greens, cruciferous vegetables, kiwi, things that are very high in vitamin K there. Okay, good. Looking for questions here. Feel free to drop them at any point. Okay. Anti-Parkinson's. Carbidopa, levodopa. This might sound a little bit mean, but I think of like dopa as like kind of like you're a little bit dopey headed. I don't know. And I feel like it fits with Parkinson's. I hope people wouldn't take offense to that, but I think of like dopiness and Parkinson's a little bit together. Improve symptoms of Parkinson's disease. That's what levodopa does. And here's the nutrition related effects. Levodopa is less effective when combined with protein. So, protein will decrease absorption of the drug. I don't want to eat protein when I take this drug, which is typically going to be in the morning. So, you want to limit protein intake in the morning because if you wake up with Parkinson's, you're very shaky, you want to take the drug, you want it to be effective through the day. So, avoid protein in the morning when you take your drug. Eat a little more carbs maybe to meet your calorie needs. And then later in the day, you can add more protein in as the drug decreases in effectiveness. So that's a kind of cool one there. Protein we don't usually see for a lot of these, so it's kind of cool. All right. Anti-neoplastics here. Methotrexate is used to treat rheumatoid arthritis. It's used as an immunosuppressant and it blocks cells' access to folic acid or folate. Cisplatin is a chemo drug, or carboplatin as well. Kills cancerous cells. That's what it does. For methotrexate, it can cause nausea, vomiting. It acts as a folic acid antagonist, like I said. So, once again, we're going to need folate supplementation in this case because methotrexate is blocking that folate access. So, you're going to lose some folate, that is for sure. With cisplatin and carboplatin, I just want you to think of classic chemo symptoms. That shouldn't be too hard for a lot of us to remember there. It's going to cause a decrease in appetite. That's going to be the most common thing that occurs when you're taking a chemo drug. Weight loss is going to follow that. And then you're mostly just going to see lots of nausea, lots of vomiting, diarrhea. I think some people can have constipation with chemo, but at least usually I see diarrhea. All right, last couple here, and then we're going into our questions. There is anti-gout medications. That's what I'm calling them. Anti-gout. Colocris, that's what I'm going to call it here. Gout, remember, it's going to be a flare up and a buildup of like the purine crystals that end up in your joints, like your ankles, your wrists, very small areas. And then those kind of like purine crystals are very sharp, and I describe them as being very inflammatory. They cause big flare ups for where they're located in joints. So, like, people are always rubbing their ankles and their wrists and elbows, things like that. So, these medications prevent those flare ups. What they do is they do cause a decrease in B12 absorption. Okay, so B12 should be recommended to be supplemented at least um, as we kind of go through here, especially. We want to also focus on a low purine diet. Okay, low purine diet. Those purine foods are going to be things like anchovies, mackerel, alcohol, organ meats. Those are going to be your really common foods that you think of when it comes to that, too. Okay, so basically, you're sticking with the same things you would normally do with kind of the gout discussion here, but just making sure that, okay, we follow that there too. Okay. All right. Excellent. Two more medications to go through here, and then we're going to move on to our questions together. We're going to have our bile sequestrants. What bile sequestrants do is they decrease and block bile acids from being absorbed, because you kind of reabsorb a lot of your bile acids here. So cholestyramine or questrin, because it's blocking those bile acids, it's blocking some of the fat absorption as well. And so we're going to see a decrease in absorption of ADEC. Okay. ADEC decrease is what we're going to see in that case. Okay. Good. All right. And then lastly, weight loss medications. I don't usually talk about this, but I wanted to drop it in here. We're not going to do diabetes medications today because it could be its whole own session on its own. So save that for another day. But for our classes here, I got two different ones. One is Orlistat. Orlistat is an interesting one. It's actually the only medication that's approved for childhood obesity, which just, that's crazy to me. So Orlistat, it causes a decrease in absorption of fats in the gastrointestinal tract. So you're just absorbing less fats in general in this case. Because you're absorbing less fats, though, this leads to these nutrition related side effects, which is one, steatorrhea. That's going to be that fattiness in the stool that you see. And secondly, a decrease in absorption of ADEC, your fat soluble vitamins, because you're absorbing less fat. It makes sense. You're going to have steatorrhea and you're not going to retain as many of those fat soluble vitamins, right? Second one, I never thought I'd be talking about, but hey, here we are. GLP-1 receptor agonists, right? Semaglutides, Ozempic, Wegovy, many other names here. We all know pretty well, I'd say, about what GLP-1 does now. It reduces appetite and blood sugars. Really, I should have put here, it's just meant to treat obesity and diabetes. That's what its purpose is. And then I picked out a couple nutrition related side effects, which I think are commonly reported. Nausea, vomiting, and diarrhea, usually some GI distress is common. Hypoglycemia, because remember, a lot of the times GLP 1s will either help insulin or prevent glucagon from excessive excretion. And so you can see dips in blood sugars. Also, you have a decrease in appetite. So naturally, that makes sense. If you're not eating as much, especially enough carbs, your appetite's going to drop and your blood sugars could. And of course, what's the point of these? They're meant to decrease weight. Hey, that was good timing. Okay. As the screen pulls up when it's ready here, whenever it decides to. Wonderful. I did drop into the chat here, folks, and I'll make sure it's in the description of the video. If you go to the link I just dropped into the chat and you want to join the mailing list so that you can get this emailed out within the next few days, please join that and we can get those emailed out or just reach out to me. All right. With our last few minutes of the night, everyone, we are going to finish with practice questions, which is my favorite part of the session here. Let me pull this up so it actually fits so you can see it. Wonderful. Wonderful. Okay. So I've got 5 questions on medications we're going to talk about. I'm going to give you all a little time to get started on them. Um, you post your answer into the chat if you feel up to it. Do that, write it out if you'd like to, or just speak it into the ether, whatever you prefer. But in some way, hold yourself accountable to what you felt like your best answer was. Let's give you 30 seconds to work through this on your own, and then I'm going to start diving in with you. Okay, perfect. So for number 1, a female patient takes long-term corticosteroids for inflammation. Which of the following is the most likely outcome of long-term corticosteroid use? Okay. Now, you know I'm all big on this if you've listened to my podcast before. What I like to give you is the best strategy I know about getting the most questions right in the exam. And my favorite is process of elimination. Process elimination is not my strategy. It's just a very common multiple choice strategy. So I love it. It's going to put you at the best odds of getting questions right. And I've had lots of students use it to really get over that hump of that last point or the last 3 points that we use here. For a low hemoglobin A1C. So I think about the corticosteroid use and I ask myself, what does it do with blood sugars? Well, corticosteroids usually spike my blood sugars. So I don't really think that this is going to be an issue of a low hemoglobin A1C. I would say actually over time, it's going to be high A1C. And because of that, I know A is not the best answer. B, osteoporosis. Well, I think this is a good answer because I remember us talking about how corticosteroids can lead to bone loss and decrease in calcium. So, because I like that answer, I'm placing a check mark by it. However, I'm going to read through each answer to make sure. C, weight loss. No, I rather think that corticosteroids would cause weight gain due to the increase in appetite and the fluid retention. That's not it. D, scurvy. Oh, that feels weird. Maybe it kind of impacts our vitamin C ability, but if I'm between B and D of what's the most likely outcome, hmm, I would say long term use. I don't think scurvy would be a long term issue that we would see with it. I think your best answer is going to be osteoporosis in that case, which is our best answer. So, using process of elimination, I was able to eliminate those other answers that I knew were not a good fit there. Good. I'll look out for questions on those. We're going to use our time just a little more effectively here. So I'm going to move on to number 2 so you're not all waiting for me. But if you have questions or comments about today, how you liked the session, what you disliked, I'm okay with that too. Drop those into the chat if you finish early on your question and let me know how I can better help you, how I can better get you to show up for more sessions in the future. Probably doing it more often. good. I'm going to start into this in just a minute. Um, so, Ebony Bright, you mentioned in the chat, just you were asking about our first question here. Um, Remember, Ebony, that the steroids, when you're taking a steroid, it will cause spikes in blood sugars, okay, cause increases. So I don't think I would see a low A1C with someone taking steroids. I'd rather see a high. I think we would end up seeing a high A1C probably because they would have such big spikes in blood sugars. Let's look at number 2 here. A patient with type 1 diabetes is taking a pro-motility agent, Reglan, daily with meals along with their insulin regimen. What influence will Reglan have on a patient's blood sugar? Okay, A, B, C, D. A, increase blood sugars more rapidly. Now, when it comes to this, I think about how this is occurring. The promotility agent is causing my food from my stomach, that would be carbs, proteins, and fats, to go more quickly from the stomach to the small intestine. Okay. Basically, food is going to travel faster to get to this point. I think A would be a good answer I'm going to hold on to because if things are going to move faster through my GI tract, then I think my blood sugars are going to go up faster too. Okay. So let's think about that as we kind of go forward here. B, no effect on blood sugars. Okay. I'm going to put a little question mark by that one. C, control blood sugars. I don't think that's the goal of what Reglan really does. I don't think it controls blood sugars. Rather, I think it's going to cause some variations in it. D, increase the effect of insulin. Well, no, it doesn't increase the effect of the drug. That's not what it does in this case. So everyone, with this question, what I'm trying to emphasize is that if I'm taking, let's say I'm taking insulin every day before meals, like 30 minutes before my meal, I take my insulin, it kicks in so that when I eat my meal, my blood sugars stay nice and controlled, right? Well, what if I still take that insulin 30 minutes before, but then I take Reglan? Well, what's going to happen is that food is going to hit my blood sugar. It's going to get absorbed quicker than what my insulin is used to. Does that make sense? So if it's moving through my system quicker, my insulin kind of needs to catch up a little bit. So your blood sugars, this is what I would expect them to do, increase a bit. And then once that insulin kicks in, they're going to level out, right? But why I think A is our best answer here is because things are moving faster into my bloodstream. Okay. So unless I took a real rapid acting insulin, I think we're going to get a bit of spike in blood sugars, increase more rapidly. And then once the insulin kicks in, it's going to level off there. That's what I would expect to happen. And that's why I feel like A is my best answer here. We talked about this a little bit today with pro-motility agents. Okay. Good. Looking up for questions on that. You're all doing very good. Remember, this is practice. It's all we're trying to do is practice. It's all we need to do. Not meant to assess you, not meant to say, do you know this or not? It's all meant to be practice. So if you want to walk away with anything today, walk away with what we learned earlier and that process of elimination I'm using here. Let's see if you can apply it for 30 seconds on question number 3. Let's see what you got here. Good. Look at those great answers in the chat here. We're doing great here. Wish this thing would pop back up. Okay. A, B, C, D. A young woman who is taking oral contraceptives should be evaluated for a deficiency in blank. For answer A, vitamin A. No, I don't think it would be vitamin A in that case. B, calcium. I don't think contraceptives are really going to affect calcium too much. Iron, maybe. Maybe that could be it because, I think of contraceptives, I think of menstruation, I think of things like that. So that's a maybe with a young woman, especially. But D, folic acid. Folic acid will actually be our best answer when it comes to this. Really commonly, when someone is taking contraceptives, it causes a decrease in their folic acid. So they may be deficient and they may require a supplement as a result of that. So definitely refer back to that chart that we just reviewed when you're looking at oral contraceptives and knowing how they impact folic acid specifically. Really good one there, folks. Nice job. Love the answers. Love everyone putting themselves out there. Love that you're trying to use the method. If you're using it, keep doing it. It's going to help you to pass exam day. Two more questions here. Move me out of the way here. Okay. I'm going to give you a little over 30 seconds with this one just because of the labs here. Okay, I'm going to move through this just slowly here a little bit. A patient is admitted to the ICU with hypertension, edema, and poor PO intake prior to admission. Their serum potassium is 2.9, serum sodium is 140, and calcium is 10.0. Which of the following diuretics would be best for this patient? Okay, so this is a classic case of we need to understand the labs in front of us and help us infer which answer is going to be best. The potassium, as I look at that, usually on my whiteboard during the exam, I would always write this out. Okay, so if I saw a lab, I would write potassium and then I would write down or up, whatever I thought it was. In this case, I'm going to write potassium. Potassium looks low to me. Okay, they're going to look low when it comes to that. Serum sodium of 140 looks kind of like average to me. Okay. It's going to look like a pretty average one, or it looks like it's just, just right there. It should be fine there. Serum calcium of 10.0, per what I know from my labs, it's around what, 8 to 12 or so. Calcium looks like it is okay when it comes to this. I'm not too worried about the different calcium levels there. So which of the following diuretics would be best? All right, well, they have low potassium. So a thiazide diuretic, a calcium sparing diuretic, this would not be a good fit. Okay. If they had low calcium, then I'm in. But because they don't have low calcium, I'm not so concerned there. Then aldactone, or spiroaldactone as it might also be known. This is a potassium sparing diuretic. This would be a good one to take because we want to take something that's going to help us to retain potassium. Our potassium is currently low, folks. We don't want it to go lower by taking a diuretic. So we need to take a diuretic that's going to spare or keep my potassium. B would be a good answer because of that. Because if I take B, I'm going to hold on to a little bit more of the potassium. C, Lasix, loop diuretic. This would not be a good fit because Lasix especially causes us to lose potassium. In D, furosemide. You may or may not have known, furosemide is another word for a Lasix or loop diuretic. This will not be a good fit either. My best fit based on these labs is that if I have a low potassium, I need to take a potassium sparing diuretic. That's going to make B my best fit for number 4. I like that question a lot. I like how it adds multiple elements and makes you take a medication inference from it too. You're all doing great. Number 5 is the last one we're going to do tonight. Okay, last one we're going to do here, and then we're going to end our session here. I'll just have some final words before we go out later, but let's work on number 5 as our last one. Stay positive and finish strong. A patient is taking an ACE inhibitor called lisinopril. Which of the following diets would be best for the patient while taking this medication? A, B, C, or D? For A, high amounts of fruits and vegetables at every meal. Hmm. Well, you know what? Maybe. Maybe. I'll just put a little question mark by this. Doesn't sound so bad for someone with high blood pressure to be taking a bunch of fruits and vegetables, right? So I'll just put a question mark by that right now. B, roasted lean proteins with salt substitute new salt. Oh, well, the roasted lean protein sounds pretty good to me. However, I don't think we want to do that new salt, right? The new salt's going to be no good because it's a salt substitute, and salt substitutes have a lot of potassium in them. And ACE inhibitors like lisinopril, they cause us to retain more potassium. So we do not want B. I don't like salt substitutes. I know that when it comes to blood pressure medication. C. Wheat bread with low sodium deli meat and Swiss cheese. I don't know. I mean, the wheat bread might have some salt in it, but in general, I wouldn't call this the saltiest meal. I wouldn't even call it the highest in potassium either. I'm going to hold on to C. D. Bacon, egg, and cheddar cheese biscuit with salted French fries. Oh boy, that sounds wonderful. Certainly, would it be good for someone with high blood pressure? No, probably not. Right? Probably not a good fit because of the salted French fries. It's high in fat. It's probably not the best option for them. Biscuits tend to have a lot of salt in them too. So I had A as a question mark, and C seemed pretty good to me. So I'm kind of at that 50-50 shot. And this is the reminder, everyone. On the exam, you're going to have a 50-50 shot on lots of answers. That's where you want to be. That's the best spot to be in the world because you're a coin flip away from getting the question right. Now, if it's a question you really don't know the answer, pick your best answer, go with it, and move on. But if you're kind of like me right now, where you're leaning between A and C, maybe you're not sure of A, but you feel better about C, choose what you feel is your best answer and move on from there. C will be our best answer in this case. In A's case, fruits and vegetables are going to have a lot of potassium in them. So A is not even a bad answer. It's good and healthy for someone with blood pressure issues to be eating fruits and vegetables, right? However, like I said before, ACE inhibitors cause you to retain potassium. That is why B is a bad answer. That's why A is a questionable answer, because with all that fruits and vegetables, you're going to retain a lot of potassium, and you're already doing that on this drug. So that's why it's two decent answers, but C is your best fit. One, because it's not going to be too high in potassium, and two, in general, I'd call it a pretty heart healthy, low sodium type of meal that would fit in there. Okay, well, that decided to kick out last minute. Okay. Well, sorry if I cut anyone short on that last question. Here's where that is before we end here. Good. Just so you have time with that too. All right, everyone. So we have reached the end of the session at this point. I asked for some comments in the chat there. If you do have any more comments, be sure to let me know. I did post in the chat there that link to join the mailing list. If you do want to get that PDF, I'll try to get that out to you, usually by Sunday or sometime after Memorial Day. I'll try to get that out to you here so you can reference it, or maybe earlier. Um, Biggest thing to remember tonight, always stay positive when you're studying. Keep working forward. This exam is a journey. It's very difficult, but you absolutely can do it. Do me a favor, continue listening to the podcast. Let me know how I can help you even more. Share with other students so that they know there's other free resources out there. And as always, happy studying to you, RD2B, and I'll talk to you really soon. Okay? Bye, everyone. Have a good night.